Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief 5-minute expert video will spotlight the daily hot topics from the conference.
Hi, this is Dr. Paul Sachs, and I'm coming from Seattle, where we have the Conference on Retroviruses and Opportunistic Infections. And today was the first real day of data, and the focus was on prevention. It got off to a very good start with a plenary session by Dr. Rafi Lanovitz from UCLA. He did a superb overview of sort of state-of-the-art on pre-exposure prophylaxis, PrEP, the data that we have thus far, the rationale behind implementation, the challenges, and what we have to look forward to. And that led very nicely into what I thought were two of the best studies of the day. The first one was the PROUD study. The PROUD study was a study done in gay men in England, looking at kind of the real-world approach to pre-exposure prophylaxis, although using a randomized design. And they included 545 high-risk HIV-negative individuals and randomized them to immediate pre-exposure prophylaxis with tenofovir FTC or Truvada, or to delay for 12 months and start it then after. It was open label, so they knew whether they were taking active drug or not. They didn't find any difference in risk behaviors between the people getting the active drugs and the placebo. And the Data Safety Monitoring Board came in and told them to stop the study early because there was such a good effect in the pre-exposure prophylaxis arm. There were only 3 infections in the people taking PrEP versus 19 in the deferred arm. This was highly significant and an 86% reduction. And it really demonstrated that this could be done in real-world settings when people were not thinking they were taking placebo. And it really should sort of reinforce that PrEP is a viable option in the community. The second study is a study called IBRGE, and was done in France. And we'd seen the study design before, and it looks at the whole strategy of doing intermittent pre-exposure prophylaxis. Now, there is an animal model in macaques showing that this can be done, an on-demand pre-exposure prophylaxis for exposures. And so they tested the following strategy. It was 2 Truvada pills taken 2 to 24 hours before sexual exposure, and then taking 1 on the next 2 days, so a total of 4 pills. And patients were randomized in a placebo-controlled fashion to receive either this intermittent strategy or placebo. And it enrolled about 400 patients. As I mentioned, it was done in France. And again, a Data Safety Monitoring Board came in and told them to stop the study early because of the high level of efficacy seen in the PrEP arm. There were only 2 infections in the intermittent arm, 14 in the placebo arm, highly statistically significant. One thing I thought that was interesting in this study was they showed that about 14 pills on average per month were taken, so that if this strategy were adopted, it would be a significant reduction in the number of pills taken compared to daily prophylaxis. So these studies were both excellent news and really do argue that we should be increasing our use of pre-exposure prophylaxis in the highest risk individuals and in most developed countries, that is, men who have sex with men. Now, these studies did recruit from the highest risk population within the group of men who have sex with men, but it is something at least we should think about more often. Now, as Dr. Lanovitz said in his plenary, how to actually accomplish this is still a challenge. A lot of the people who need to prescribe pre-exposure prophylaxis are going to be primary care physicians, primary care clinicians, because specialists may not be seeing HIV-negative individuals. But I think these studies will reinforce the importance of PrEP as a prevention effort. The third study related to prevention is the PROMISE study. The PROMISE study looked at prevention of maternal-to-child transmission of HIV, something that we can do very well with our current triple therapies. But the question is, which is the safest intervention? We found in this study that yes, triple therapy was better than regimens that use, for example, single-dose nevirapine with zidovudine during pregnancy, but we've actually kind of suspected that for a while. So the 2 triple therapy regimens tested in this study both included lopinavir-ritonavir, and then one of the arms had zidovudine lamivudine, and the other one had tenofovir emtricitabine. And for whatever reason, there were more severe adverse pregnancy outcomes in the group randomized to receive tenofovir emtricitabine. This is actually quite concerning in many ways because this is a regimen that we're commonly using in the United States right now. And really what I think it's telling us is that this is still an open question. There is not a regimen for pregnant women that is ideal for safety for the HIV-negative but exposed infant. And that's an open research question, and I hope that we'll find in the future some strategies that may be safer. So that's some of the highlights from today's Conference on Retrovirus of Opportunistic Infections, and I look forward to speaking with you again tomorrow.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.